Hello and welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for November 15th, 2023. Thank you for joining us this month. Our presenters today are Elizabeth Fallon and Tyler Leitz. Dr. Elizabeth Fallon is an epidemiologist within the Arthritis Management and Wellbeing Program located within the Division of Population Health at the Centers for Disease Control and Prevention. Beth conducts research to describe the arthritis burden in the United States in terms of prevalence, health outcomes, and costs. She also conducts research to describe arthritis self-management behaviors among persons with arthritis and understand how healthcare providers and health systems can be leveraged to increase self-management behaviors among persons with arthritis. Tyler Leitz is an ORISE Fellow in the Arthritis Management and Wellbeing Program located within the Division of Population Health at the Centers for Disease Control and Prevention. Tyler's dual role fellowship focuses on increasing the awareness of arthritis burden through health communications programming, as well as conducting research on arthritis prevalence and strategies for the management of this chronic condition. The title of today's presentation is Arthritis Prevalence Across the Lifespan. Tyler, I'll toss it over to you to get things started.
Thank you, Katie. Good afternoon, everyone. Again, my name is Tyler Leitz. I am an ORISE Fellow in CDC's Arthritis Management and Wellbeing Program. Today, I am going to present on the childhood arthritis prevalence. I will then pass it off to my very esteemed colleague, Dr. Fallon, who will present on the adult arthritis prevalence. Let's jump right on in. All right, so some background on childhood arthritis. Childhood arthritis is a general or an umbrella term which most commonly refers to 7 acquired autoinflammatory conditions. For the sake of time, I would refer you all to the full report to read what those 7 conditions are. However, childhood arthritis is associated with joint pain, swelling and stiffness, physical disability, activity limitations, depression, anxiety, and it can persist into adulthood. Some previous estimates of the childhood arthritis prevalence range from 13,400 in a 1983 study to 294,000 in a 2007 study. So in order to update those estimates, CDC analyzed 2017 through 2021 National Survey of Children's Health data. The National Survey of Children's Health is the largest national and state level survey of US children's health, and it also uses a national address-based sample for the online or mail collection of data from parents. We wanted to look at the overall childhood arthritis prevalence as well as the prevalence by selected characteristics, and we did so by looking at cases per 100,000. Our case definition was diagnosed arthritis, which we operationalized as parents answering yes to the single survey question: has a doctor or other healthcare provider ever told you that this child has arthritis? We also looked at differences in subgroups, which were tested against a reference group using a t-test with a priori alpha level of 0.05. So overall, between 2017 and 2021, we found that an estimated 220,000 US children and adolescents had diagnosed arthritis. This translates to about 305 cases out of every 100,000 US children. And we also found that the prevalence increased with age and was highest among those aged between 12 and 17 years, When looking at the childhood arthritis prevalence by race and ethnicity, we found that Black children had the highest arthritis prevalence, followed by children of multiple races, white children, American Indian and Alaska Native children, and finally Native Hawaiian and other Pacific Islander children having the lowest arthritis prevalence. We also looked at the arthritis prevalence by mental health status, more specifically for the presence of depression and anxiety. And we found that children with diagnosed depression had a higher arthritis prevalence compared to children without depression. Similarly, we found that children with diagnosed anxiety had a higher arthritis prevalence compared with children without anxiety. We also looked at the arthritis prevalence by some other social factors and found that children from households experiencing food insecurity had a higher arthritis prevalence compared to children from food secure households. We also found that children from households with smoking, they had a higher arthritis prevalence compared with children from non-smoking households. And finally, we found that children of parents with less than a high school diploma, they also had a higher arthritis prevalence compared with children of parents with a college degree or higher. So what implications do these findings have for public health practice? Due to the disproportionate burden of arthritis by race and ethnicity and across other social factors, assessing and addressing social determinants of health, as well as systemic factors that might contribute to disparities should be prioritized. Similarly, due to the comorbidity between depression, anxiety, and arthritis, screening for mental health conditions and linking children and adolescents with arthritis to mental health services should also be a priority area. And finally, developing self-management interventions for children and adolescents that improve physical activity and weight control are critically important. I am going to stop here, but I would again encourage you all to read the full report. There are a few other findings that we did not include in this presentation for the sake of timing. So if you scan this QR code, it will take you to a page where you can download that report. I would also like to encourage you all to check out Healthy Living with Arthritis. It is the Arthritis Management and Wellbeing Programs podcast series. That series features an episode discussing this report, as well as an episode discussing Dr. Fallon's report. There is another QR code later in the presentation, but it is also pretty widely available on streaming platforms. I believe it is available on Spotify, Pandora, Amazon, and a couple of other streaming platforms, as well as being available in CDC's Public Health Media Library. I'm going to stop there and pass it off to Dr. Fallon. Thank you, everyone.
Thank you, Tyler. I'm going to pick up a little bit where Tyler left off, discussing the prevalence of diagnosed arthritis among adults 18 years and older. And similar to Tyler, I'll take you through a brief introduction, the aims of this study, methods, results, discussions, and implications. Next slide, please. So we know that arthritis is a general term that's used to describe over 100 conditions that have similar symptoms, potentially including joint inflammation and swelling. And arthritis leads to health outcomes such as pain, physical limitations, and disability, and is extremely costly to individuals as well as the US healthcare system. So in the pie graphs on the right, you can see that among adults with arthritis, about 30% report work limitations, 44% report activity limitations, and 11% are reporting social limitations. Next slide. So the purpose of this study was we wanted to update our US arthritis prevalence estimates. I'll talk a little bit more about this in a moment, but the National Health Interview Survey, which I'll just call NHIS from here on out, was redesigned in 2019. So these estimates from 2019 to 2021 are going to establish a new baseline from which we'll track the prevalence of arthritis moving into the future. And the study also allows us to identify health disparities or groups of people who are carrying a disproportionate burden of arthritis. Next slide. So the NHIS survey is a nationally representative survey. One adult in a household that is selected is then, that one adult is then randomly selected to complete the in-home interview. In 2019, this survey was redesigned in order to reduce the overall number of items that they were asking and reduce the amount of time that individuals were asked to engage in the survey. Additionally, when they did that, the items were also reordered, and they also developed a new weighting algorithm to make sure that the estimates that we get are generalizable to the United States population. For all 3 years, 2019 to 2021, we did get good response rates, averaging around 50%. And for this study, we defined an individual as having arthritis if they answered yes to the item, have you ever been told by a doctor or other health professional that you have some form of arthritis, rheumatoid arthritis, gout, lupus, or fibromyalgia? Next slide, please. So a little bit about the NHIS data collection during the COVID-19 period. So before COVID-19 epidemic, again, it's typical to conduct the survey or the interview in a person's home. And if any follow-up is needed, to then contact that person by telephone only for follow-up questions. In April of 2020 through June of 2020, due to the COVID-19 pandemic, the way that they collected the data changed for safety purposes. And in this case, they collected the data purely by telephone. In July from 2020 to April 2021, they continued to collect the survey primarily by phone, but did do some in-home follow-up when needed. And then in May of 2021, they returned to the pre-pandemic ways of collecting this data. So the data was not collected the same throughout this study period. Next slide. Because of those changes with the NHIS data and how it was being collected, we did go through a process of looking at the data by single year to see if there were any, massive changes in arthritis prevalence from year to year. And we did not see that. So that made it safe for us to pool the data into this 3-year time period. And that's important so that we get kind of, I would say, smoother estimates of arthritis so that we don't feel like arthritis prevalence is going up and then down and up and down from year to year. We did use age standardization to the 2000 US projected adult population in 3 age groups. So 18 to 44, 45 to 64, and then 65 and up. And we used statistical programs that account for complex sampling design and sampling weights, which is all standard practice in this particular field. We calculated prevalence overall, and then also by select demographic characteristics, and we used t-test to determine if there were significant differences between subgroup categories. Next slide. So our overall finding is that among adults 18 years and older, 53.2 million US adults have arthritis, and that's about 1 in 5 US adults, or if you'd like to say 21%. Next slide. When we look at arthritis prevalence by age, we have some important findings that are going to be informative for how we communicate about arthritis prevalence. Many people are aware that arthritis prevalence increases with age group, and you can see that here where adults 65 years and older have higher arthritis prevalence compared to adults in the 2 younger age groups. And sometimes this is the reason why people think of arthritis as a disease among older adults and kind of don't think of it as something that happens to younger adults. But you could also look at this data and say that 88% of adults with arthritis are 45 years and older. So that would be our middle-aged adults as well as our older adults. And another way to look at it, especially important if you're working with work sites, is that about half among adults with arthritis, half are below the age of 65. So this is when individuals are focusing on their careers and raising their families. So it's important for us to communicate that arthritis is not just a chronic disease of just older adults. In fact, it is affecting adults across the lifespan. And of course, as Tyler pointed out earlier, can also affect individuals below age 18. Next slide. We also looked at prevalence of arthritis among veterans and non-veterans, and we find, similar to previous research, that the prevalence of veterans is higher compared to non-veterans. So although in the general US population, you heard me say that 1 in 5 have arthritis, among veterans, in this case, according to this data set, it's 1 in 4. This also did entice us to do a deep dive on arthritis prevalence among veterans, and I'll give the QR code for that paper that was just released last week for Veterans Day at the end of this presentation. Next slide, please. We also found that arthritis prevalence is higher among adults with a disability than those without a disability. And this is important to think about for individuals who might be offering self-management programs, physical activity programs for adults with arthritis, is that you'll see a lot of individuals who also have comorbid disabilities, and we want to make sure that we're able to ensure that they are able to engage fully in those programs. Next slide, please. We also looked at arthritis prevalence among individuals who report another chronic disease. And what you see here is in this graph is among individuals with dementia, COPD, stroke, heart disease, diabetes, cancer, and obesity. If a person has one of those chronic diseases, their arthritis prevalence is higher compared to individuals who do not have those chronic diseases. And so again, this gets back to this idea that arthritis and other diseases are happening together. And then the next slide shows the same idea, but it's broken out by age group. Next slide. So this shows that in the white bar or the clear bar, if you will, that would be individuals 18 to 44 years. The striped bar is individuals 45 to 64 years. And in the solid bar is individuals 65 years and older. And I've put a red line across the top just showing that for adults who have one of these chronic diseases and who are also over 65, over 50% are also going to report arthritis. So it's just very important to realize that we try to work with individuals as a whole person across all of these different chronic diseases. The other thing to think about is that for these chronic diseases, oftentimes lifestyle change can be beneficial to their health. And arthritis might actually be a barrier to, for example, engaging in physical activity for these individuals. So really something important to think about moving into how this information is applicable for the future. Next slide, please. So just to recap, we know that 1 in 5 US adults has diagnosed arthritis. That's about 53 million US adults. But that arthritis is higher among some groups compared to others. So it's higher among adults over 45, higher among veterans, and higher among persons with disability. And that half of all adults 65 years and older with a chronic disease also have diagnosed arthritis. Next slide, please. So just something to think about. We do know that, again, that the NHIS survey was redesigned in 2019, where items were eliminated from previous surveys or reordered. There were changes to the weighting algorithm. So it's very important that we do not compare these NHIS estimates to estimates that were gained from that same survey before 2019. Instead, this is a new baseline moving forward into the future. There's also some limitations with this study in that arthritis diagnosis was self-reported. So for example, there may have been some type of recall bias or social desirability bias in individuals answering whether or not they had arthritis. Also, we were not able to capture anybody who has undiagnosed arthritis. So for example, maybe a person is experiencing symptoms, but they haven't talked with their healthcare provider yet, or maybe they don't have access to the healthcare system to get a diagnosis. We're not able to capture those individuals within this estimate. And finally, because COVID-19 necessitated changes in how the NHIS data was collected, that could have also potentially affected our estimates, although we don't think, based on some other analyses and things that we did, that that was necessarily a large effect on our estimates at this time. Next slide. So implications for public health practice. Again, there's a lot of people that have arthritis. It's a very common chronic condition in the United States. There's disproportionate burden among certain groups. And we do know that we have evidence-based interventions that are arthritis appropriate to help people increase their physical activity or attend an arthritis or a chronic disease self-management education course. And we need to focus in public health on increasing availability of these ABIs and the accessibility of these ABIs for all groups, especially those who have disproportionate burden. Next slide. So that's all I have today. I'll ask to go to the next slide where you'll see all of the QR codes that we have. You can see that we have a QR code if you would like to subscribe to our arthritis management and well-being newsletter, subscribe to the podcast that Tyler mentioned earlier. You can also use the center top QR code to get the full report on childhood arthritis. The full report on adult arthritis is in the lower right. And then the new report for arthritis among veterans you can get by going to the QR code in the upper right. And that's all I have.
Great. Thank you so much, Beth. And thank you, Tyler. Really appreciate you distilling this data down for us so that we understand it and understand the impact of arthritis on children and adults. And I did, in addition to these QR codes, which are great, thank you for including those, I did put the 3 main publications, a link directly into the chat for those of you who might want to access it on your computers. Tyler, I'm going to start with a question for you. First, I should invite anyone in attendance today. If you'd like to ask Beth or Tyler a question, please type those into the chat and I will read them aloud for them to answer. While we're getting started, Tyler, I was going to ask you, and I'm sorry if I missed this, but I know Beth mentioned there was some difference between the current study and the previous study in terms of prevalence rates. And I was wondering if you had found that in the childhood arthritis prevalence rates as well.
Yeah, that's a great question. Thanks, Katie. So to answer that, yes, there is an apparent decrease in the prevalence. The most recent study was published in 2007. And that study had a prevalence estimate of 294,000, whereas the 2023 study has a prevalence estimate of 220,000. But the largest difference between those studies were the case definitions used. So the 2007 study used a case definition that included significant pediatric arthritis and other rheumatologic conditions. In that study, they mentioned a limitation was the fact that the other rheumatologic conditions are not often thought of as arthritis. And as a result of including those in their case definition, their prevalence estimate was largely or likely overestimated. But additionally, there were 2 different surveys used. So I'm spacing on the exact name of the 2007 survey that was used, but we use the National Survey of Children's Health. So in addition to using different case definitions, we also used different surveys. So they're not very comparable, but I will also add that the confidence intervals do overlap between those 2 studies. So it is more likely that the 220,000 estimate was closer then and now to the real estimate. That was a long answer, but I hope that gets at that.
Thank you, Tyler. It sounds like, again, it's kind of study design, but still the impact of arthritis and the number, the burden of arthritis is not, that is not changed in the new study design and the new prevalence rates. So we have a question here, to your knowledge, to your both of you in your field of expertise, are there any studies going on for a cure for arthritis? And do you think there will ever be a cure or just ways to continue to manage it?
Not that I am aware of, but I will defer to Dr. Fallon.
Yeah, I have to admit that that's more a question for somebody who's on the clinical side. I do know that there are scientists looking at cellular, tissue-oriented treatments and so on, but I don't think that they've reached that yet. My hope is eventually that there will be a cure. Keep in mind that arthritis is a general term, so the different types of treatments or cures that would be studied for rheumatoid arthritis would be very different than what you might study for osteoarthritis and so on. So I'm hopeful that there will be, but again, that's not my area of expertise, so I can't comment in a more specific way at this time.
That's helpful. And I think that question brings up a good point, just and both of you did mention this to some degree, but as far as kind of management, we do know that these prevalence rates describe the burden of arthritis on hundreds of thousands and millions of people in the country. And so it is very important from a public health perspective to provide resources and supports for managing these various conditions. And so maybe you could each just take a minute to talk a little bit more about some of the specific community resources or resources that you have available for each of the age groups as far as managing arthritis. And again, knowing that there are a variety of different types of arthritis within that larger category.
Sure, yeah, I'll start that off. I can honestly say this might be a challenge for the larger public health community, developing ABIs that are specific to children and adolescents. Currently, I'm not aware of any that exist for children and adolescents. So developing those interventions is critical. I think children and adolescents are a very vulnerable population already, taking into account that they are dealing with chronic pain and activity limitations even furthers the necessity to provide appropriate management for them. So yeah, I think my challenge would be developing those ABIs because there currently aren't any.
I think on the adult side, for 18 and over, we do have a lot of self-management programs, physical activity programs. I see that Katie put into the chat, when we say ABIs, it means arthritis appropriate evidence-based interventions. So these typically are interventions that have been published in the peer-reviewed scientific literature. They've been shown to improve arthritis outcomes, whether it be pain or physical function or weight loss, and that those improvements that they see also are maintained for a significant period of time. So on the adult side, we do have several. I'm hoping that Katie or someone from the OA Action Alliance has at the ready the website that shows our complete list of ABIs that are available. You can, if you're interested in one of those programs or learning more about them, you can visit the OA Action Alliance website. You can also visit the cdc.gov/arthritis website. And you could also call the Arthritis Foundation helpline, which is 1-800-283-7800, to help locate a program in your area. And then there are also virtual options that you can do. Maybe if you live in a rural area or you have a schedule that changes a lot, and it's hard for you to attend something that happens at the same week at the same time, there are virtual options and self-paced options as well. So I think we do have a lot of good self-management programs available, but I think there's, in my opinion, there's always room for more because each person with arthritis is different and has different needs. So we're always kind of working towards providing more resources for individuals to help them manage their condition and their symptoms.
Great, thank you to both of you for answering that question. We have another question here. Given the perception that OA is a disease of older age, do you think it is likely that OA is therefore less likely to be diagnosed in middle-aged adults, or that middle-aged adults are less likely to see a healthcare professional? The implication is that the OA estimates presented, or the arthritis estimates presented, particularly among the middle-aged group, are potentially underestimates. Guess that's for you, Beth.
Yes, that is a possibility. So I did talk about in the limitations section that we're not able to account for anyone that has undiagnosed arthritis. So for example, maybe they don't have regular access to the healthcare system, or when they are speaking with their physician, maybe they have another health priority that they're talking about first, and they kind of don't get around to talking about their joint pain or swelling that they may be experiencing. So definitely, and in this field, this gets a little bit technical, so apologies, but we do calculate something called confidence intervals, which gives us a little bit of error, but I do think that this is something that individuals and through our different awareness campaigns, we need to be encouraging individuals to discuss their joint pain with their healthcare providers. They should not consider it as something that's quote unquote just going to happen as I age. It's inevitable. It is something that can be treated comprehensively, both through self-management as well as different treatments that we do have available in the medical system. So just, I think, the helping people to become aware that this isn't something that they should ignore. It is something that they need to bring up and to address, because by addressing it sooner, hopefully they can get to feeling better sooner and prevent further deterioration within their joints.
Thank you, Beth. And we'll take this one last question, which honestly could be an entire webinar in itself. So, Beth, maybe you can hit the high points. Has any data indicated any correlation between the level of exercise, such as walking, and OA prevalence?
So again, our definitions are usually all types of arthritis. Most of our data doesn't focus on any one specific type, at least the data that comes from CDC. But I can say that generally speaking, we know that adults with arthritis are less physically active than adults without arthritis. And then you might imagine that if an individual maybe is experiencing joint pain, which some people have arthritis but don't experience a lot of joint pain, others do. So anytime somebody's experiencing that or has a disability, we know from other data that individuals with disabilities or activity limitations are less active. So yes.
That's great. And of course, we know that physical activity, walking being one example, is a great way to help manage arthritis symptoms. So thank you for that information. And thank you so much again, Beth and Tyler, for your presentations today. Congratulations on these wonderful publications. And thank you to everyone who attended today's presentation. I'm going to pop a poll here. So if you have a chance to take that before you leave today, we would appreciate it. And finally, we hope you'll join us next month on December 13th for our Lunch and Learn featuring Dr. Amanda Nelson, who will present multi-joint arthritis. And I'll drop the link to that registration here in just a moment. And again, we will follow up today's presentation with an email that links to all of these resources shared and a link to the recording. So thank you all, and that concludes today's presentation.